Welcome. Today we will be discussing the assessment and management of a patient presenting with symptomatic bradycardia. We will cover how to identify the condition, the primary algorithms for treatment, and the pharmacological and mechanical interventions used to stabilize the patient. Not all slow heart rates require intervention. A well-trained athlete might naturally have a heart rate in the 40s. We focus on symptomatic bradycardia, which exists clinically only when 3 specific criteria are met. The heart rate is slow, the patient has symptoms, and crucially, those symptoms are actually caused by the slow heart rate, rather than another underlying illness. Several rhythms can present as bradycardia. These include sinus bradycardia, first-degree AV block, second-degree AV block types 1 and 2, and third-degree or complete AV block. Recognizing the specific type of AV block is an important secondary goal, because complete AV block is the most likely to cause cardiovascular collapse and require immediate pacing. When assessing a patient, you must perform a focused history and physical exam to identify adverse signs and symptoms. Symptoms can range from fatigue and dizziness to chest pain and syncope. Observable signs often include hypotension, diaphoresis, or even acute heart failure. Always ask yourself, are these serious signs related to the slow heart rate, or is something else causing them? Let's look at the adult bradycardia with a pulse algorithm. It begins with identifying the slow heart rate, typically less than 50 beats per minute. Step 2 involves the primary assessment. Support the airway, provide oxygen if the patient is hypoxemic, place them on a cardiac monitor, establish IV access, and obtain a 12-lead ECG. However, never delay immediate therapy to get that ECG if the patient is unstable. Seriously, the primary decision point in the algorithm is determining if the patient has adequate or poor perfusion. You must ask, is the bradycardia causing hypotension, altered mental status, signs of shock, ischemic chest pain, or acute heart failure? If the answer is no and perfusion is adequate, you simply monitor and observe. If the answer is yes, you must move quickly to intervene. For patients with poor perfusion, atropine is the first-line drug. The standard dose is a 0.5 milligram IV bolus, repeated every 3 to 5 minutes, up to a maximum total dose of 3 milligrams. However, use it cautiously in patients with acute coronary ischemia, as increasing the heart rate can worsen an infarction. Also, do not rely on atropine for Mobitz type 2 or complete heart block, as it is unlikely to be effective in those cases. If atropine is ineffective or if the patient has a high-degree heart block, transcutaneous pacing, or TCP, is your next step. You will set the pacemaker's demand rate to about 60 beats per minute and adjust the current until you see consistent electrical capture, then add a 2 milliamp safety margin. Because TCP can be painful, provide sedation if the patient is conscious. And remember, never use the carotid pulse to confirm mechanical capture, as the electrical stimulation causes muscle jerking that mimics a pulse. If pacing is ineffective, or as an alternative to pacing, you can use chronotropic drug infusions. Dopamine is infused at 2 to 20 micrograms per kilogram per minute, while epinephrine is dosed at 2 to 10 micrograms per minute. Both are titrated to the patient's response. Because both drugs are vasoconstrictors, it is crucial to assess the patient's volume status first to avoid complications from hypovolemia. When the heart rate falls too low, lower pacemakers in the ventricles may generate escape rhythms. These wide complex beats can sometimes precipitate dangerous arrhythmias like VTAC or VFib. Pacing helps by increasing the baseline heart rate, which naturally suppresses these escape rhythms. Additionally, always place pacing pads on patients with acute myocardial infarction who exhibit high-risk blocks so you are ready for standby pacing if they suddenly deteriorate. To wrap up, managing symptomatic bradycardia comes down to a clear sequence. Identify the slow rate and confirm it is causing poor perfusion. Support the airway and breathing. Give atropine as your first-line drug. If that fails, or if you are dealing with a high-degree block, move immediately to transcutaneous pacing or chronotropic infusions like dopamine or epinephrine. Finally, always be prepared to seek expert consultation for transvenous pacing.